Good afternoon, everybody. Hello, my name is Grant Turek, and today I have the privilege of moderating today's talk. This is going to be a CME accredited event, and you'll find the link in the chat by the end of the conversation. This was made possible due to an unrestricted educational grant through both Jazz Pharmaceuticals and Aquestive Therapeutics.
I think, I'm sorry, Grant. Actually, let's give it a few minutes. I see that people are now coming into participants. So I apologize. I'm just seeing the number of participants. It's almost like we have standing room only. So basically, we have people coming in. So maybe just allow the few people to come in. Hey, Grant, sorry about that, Grant. I didn't mean yet. You're on a roll.
Well, now the people who are here already are going to realize that I scripted that whole thing. So.
Come on. Anyway, I apologize. I didn't want to do that. I just saw the number starting to climb. And
yeah, sure. Whenever you want me to get started, just let me know.
Right. Yeah, I mean, most times, as we all know in these talks, people sign up and, they don't all come in and they wait for the archive version, but it's all good. I just see it right now. I'm looking at the number count. As soon as I see it, it's almost like popping popcorn. I don't know what's the equivalent. When do I take the popcorn out of the microwave? And there's a few more kernels left, right? Wait, not the greatest analogy, but anyway, I apologize. But Grant, why don't you go ahead? I mean, I apologize. Why don't you go ahead and start?
Sure thing. So to start where I left off, hello, my name is Dr. Grant Turek, and I have the privilege of moderating today's talk. For your information, this will be a CME accredited event, and the link should be available in the chat by the end of our conversation here today. This talk was made possible by an unrestricted educational grant through Jazz Pharmaceuticals and Aquestive Therapeutics. To start, we'll have Professor Christine Linehan, the director of the Center for Disability Studies at the University College Dublin, speak briefly about her role and efforts with the International League Against Epilepsy's Intellectual Disability Task Force, and of which she is the chair of. And then after her, Dr. Seth Keller, the former president of the AADMD, and a physician passionate about medical education as it pertains to the care of the IDD population, will share the historical foundations of medical care given to this patient population. Hopefully, time allows for questions, which we will save to the end, but I invite you to put those questions in the webinar Q&A chat section, and we will do our best to address them. And since I have your attention now, I want to put on your calendars January 18th at noon, Eastern Standard Time, when we will have the second part of our webinar series led by Dr. Mackenzie Cervenka. And without further ado, Professor Linehan.
Hi, thank you, Grant, and to Seth as well. I'm joining you from Dublin, Ireland. So it's 4 p.m. in the afternoon here on a crisp autumn day, but I'm delighted to be asked to contribute just some introductory comments here. So thanks to everybody and all the participants and AADMD. I think Seth asked me because you said there, Grant, in my role as chair of the very wordy International League Against Epilepsy Intellectual Disability Task Force under the Psychiatric Commission. So it takes quite a lot to say that. But essentially, ILAE, as I know it, the International League Against Epilepsy, is exactly that. It's a large international organization of people interested in the area of epilepsy. And I'm extremely privileged to chair one of the task forces in the league, and that is specifically to do with supporting people with intellectual disability who have epilepsy. So if anybody's interested to join, you could email me or just have a look on the website if you Google my name. But we're a small band, and anybody who has an interest in this area, we'd be interested to hear from. I also had mentioned to Seth that another part of my life is chairing another committee with a huge name. You may have come across it. It's IASD, the International Association for the Scientific Study of Intellectual and Developmental Disabilities. So it's purely the ID piece, and that's for people who are interested in intellectual disability. And there I chair the Comparative Policy and Practice SERG. So we look at policy and practice throughout the world and see if we can learn from each other. But between the two of those committees, I think what I've learned is that the answer is yes, we can learn an awful lot from each other. And anybody is welcome to join either of those organizations. As I say, the more the merrier. I think having spoken with Seth, the reason really we're here today is, in my view, is to look at something that I would call health disparity, and that is the difference between supports available to the general public and supports available for people with ID. And I'm mindful of one of your great scholars, Professor Gloria Cron. She talks of a cascade of disparity all the way through from screening and preventative healthcare right the way through to actual medical care. And we know there's this very large disparity. We've seen it in the United Kingdom in a UN or a UK confidential inquiry, where the proportion of people dying from unmet care need is almost 3 times higher if you have an intellectual disability than if you don't. And for me, all of this falls under the UN Convention on the Rights of People with Disabilities in Article 25. So we are all entitled to equitable healthcare, and particularly people with disabilities. Epilepsy is hugely important here. It's the highest comorbidity. It's more prevalent. It's more severe. Higher numbers of people die from SUDEP, sudden unexplained death in epilepsy. So we need more physicians. We need more advocates. We need more self-advocates. And I think there's nothing like this kind of an event to get together those of us who are interested in this field, and to get somebody with the passion of Seth, who I'm going to hand over to now, who I know has an excellent presentation. So could I just thank you again, Seth and Grant, for the invitation, and I look forward to hearing your talk.
Thank you, Christine. And after what you just said, I don't know if I have to say anything more. I mean, that was just a great introduction. But I think that's really wonderful, Christine. I mean, I think you really helped lay the foundation of really what it is. So this is the beginning of a 9-part webinar series on the topical area of epilepsy in adults, in particular with intellectual and developmental disabilities. And just like Christine that you said, is that the prevalence of epilepsy in this population is extremely high, and the complication is extremely significant. And in the AADMD, and I, as stated, I am the past president. As a neurologist, this is such a huge issue, and we wanted to ensure that our discussion wasn't specifically American-centric, and it really crossed the borders and the oceans around the world. So having ILE and Christine in particular speak and hear her, to realize that we're all in this together. So this first presentation is really more of an introductory webinar. And I know that for the people, I wish I could just open up the microphone and listen and hear about who is actually on this call. Is in many respects, I imagine if you tune in or found the link to our presentation, you're in caring. I mean, so again, I believe we're probably going to sing to the choir in some respect to it, but having friends and colleagues is huge. So what I want to do in the next 40 minutes or so is lay the foundation of our webinar series and give some background information. First of all, for full disclosure, I have nothing. I'm transparent as anything can be. No conflicts of interest. I have nothing to disclose at all for myself, and Grant too, and I think Christine as well. So we're there for your taking. And what I'm going to be speaking about, this is just a general outline of what you're going to hear about in the next, again, 40 minutes or so about the areas. So I'm just going to go right through this and jump into it. And this busy slide is a little busy slide with some interesting artwork, really just talked about epilepsy and developmental disabilities in the past. Because, the question is, how did we end up here? Why are we like it now in this situation that we face ourselves, not only in the United States, but in Ireland and other countries around the world? How do we end up this way? Well, it's all based on history. So the history, which is laden full of how epilepsy and epilepsy was being cared for back in Babylonian time period, is what did they know back in that time period of people that were having fits, people that were having spells. So definitely was really thought of as almost like a supernatural evil type situation in many cases. And you can appreciate that didn't bode well, unfortunately, really not funny, about people that were having these types of events, because people didn't know, they were scared and thought they were being haunted in some respect. And that type of impact was really challenging and sad for many people. And then the priests, the faith healers, the religious people that were trying to so-called heal them, went through all different ways of trying to do that. Even a quote from, or thoughts from other people back as time went on over the centuries, started looking more about improving care for people with epilepsy to the point of either doing surgical interventions on their head or doing types of healing interventions for them. Even Matthew 17:14-21, Jesus even said, made thought about the spirits come out only if you use prayer and fasting. And really the thought about that was really thought back that maybe that was thought that fasting may have been a healing part and driving out demons. Maybe that was the beginning of where the ketogenic diet really even began. We don't really know. But these kind of thoughts really over years of what fits are or seizures were really was a thing that was really uncertain about. And it wasn't a pleasant situation. And those, if you combine this with having an intellectual disability and epilepsy, only compounded more and more about the challenge that people have. There's some artwork on the side you can see about what these are in terms of the demons and trephining, which is opening up the skull and letting out these evil spirits. And even back in the 1800s, early 1900s, in the psychological aspects of what it was to have a seizure. Is it psychological? Is it hysteria? So there's a lot of myth and creation about what was going on. This is one booklet I thought really just gave some sense in the 1911, a booklet that had come out. It was called the Report of the Commission to Investigate the Question of Increase of Criminals, Mental Defects, Epileptics, and Degenerates. I mean, it's amazing this is out there. And it really talked a lot in some respect about how this population was really deemed. The community demanded protection. They were dangerous, they were troublesome, the feeble-minded. And these are just, in red, that's how I highlighted, preventing the defectives and the degenerates, the feeble-minded epileptics and insane. And even the thought about, what do we do with them? How do we protect ourselves from society? This is 1911. I mean, this is really not 100 years ago, but really it's not ancient time period back in the Stone Age. So really the comparison between the epileptic and the developmental disabilities and the criminal were almost like wrapped up all in one, about didn't even really appreciate the distinction between them. I had added this slide, and really, and I'm not really trying to throw all of our forefathers under the bus, but I think this is all based on history of ignorance and culture at that time. Even some of the forefathers in neurology, William Lennox and Robert Foster Kennedy, those for in the neurology field know them very well because of the things they did. I know in my neurology training. William Lennox and Lennox-Gastaut syndrome and what he did for EEG monitoring. But he himself, he had passed away in 1960, but in his writings in 1950, calling it the moral issue, mercy killing of children with undeveloped or misformed brains. Robert Foster Kennedy, also in that same time period, children with proven mental retardation, the feeble-mindedness over the age of 5 should be put to death. I mean, this is somewhat out of context, but these were really culturally things that really were thought to be the norm for the population back in the day. And this is, only again back in the 1950s. So this slide, I wanted to kind of move up the time period a little bit. And this is a slide that might be somewhat American-centric, and it's really talking about that was then, this is now. So where have we really gone in terms of life expectancy for those with intellectual and developmental disabilities, whether they have epilepsy or not? And really what this slide, and I had helped create the slide, it really puts on top in the back of this, the black line and the kind of the pink line about how people with intellectual developmental disabilities, and in the pink is really Down syndrome, how over the course of decades and decades and decades are indeed living longer. However, what went on culturally and socially over the course of the years, and one that was mentioned about people with developmental disabilities is warehousing and people in institution care, and even the effort of using eugenics, which is really the purification of people that were a pure blood, or people that were healthy, and really it was like the issue of sterilization. And the eugenics movement was very prominent in the United States. And really the story is from the eugenics movement in the United States is those that were like Dr. Mengele and others from Nazi Germany really were taking the lead in what they may have learned from people in the United States and take it back to Nazi Germany and lead it into what was then the concentration camps and the killing of those with developmental disabilities. And they had a specific effort called T4, the letter T and the number 4, which was really basically how they were basically putting people with intellectual disability to death. They basically they were exterminating them. And so really, this is really laid bare in about how things were back in the 1940s and up until the 50s, 60s, and even beyond. And I have a picture there with John F. Kennedy, and many of you may know that he had a sister, Rose. And Rose did have a developmental disabilities, and the Kennedy family, Shriver family, were amazingly loving and supportive of their other sister, Rose. And so that was the beginning of really, I'd say, the huge beginning of further family advocacy from the 50s, 60s, and 70s, where the association of ARC ultimately formed in that time period, and then the realization that state-run institutions in our country really were highlighted as being warehouses and really snake pits. There's a video of Robert Kennedy from the early 1960s, where he was actually interviewed and went into one of these institutions. It was just shocked about the kind of care it was. But this was really standard. So really, as the other movements went further from the 1970s up until more time period of enforcement of laws, the American Disability Act and other social mores, like even the word, the language that we use. And I know, Christine, you were mentioning about the UN charters and information. It really does require, a global effort, the Convention on the Rights of People with Disabilities, and even for us in the AADMD, back when I became a member, back in the early founding of the AADMD, it was closing the gap by our Surgeon General, David Satcher, about having us to get together and say, we got to do something as healthcare providers in the United States. We got to do something. So the AADMD was also formed really based on the reality of disparities and lack of equity of care. So really things are for that reason. And this population really, as getting into it, for those that they're living longer now. I mean, as a state, they're living longer, so they may not have their parents, they may not have their brothers or sisters, and they might sometimes be either living with their aging parent, perhaps, or maybe living in community living, or maybe foster care, or maybe even in some state institutions. And I hate to say, may not be cute and adorable anymore. I'm being facetious in my comment about that, but that's kind of really sometimes where people may look at them and say, these are not the same people. I don't think of them as little children anymore. And sometimes they're kind of given a raw deal by even their appearances, and they're not with their children. They're definitely living longer, but and in terms of even the issues for us as healthcare providers, is that often as they're getting older, the pediatric providers, the pediatric neurologist in the case of epilepsy, they're often transitioning care to find an adult-oriented healthcare provider, at least for the neurologic standpoint. And where do they go? Where do they find these so-called specialists? I'm kind of rhetorical in that comment. And most neurologic care, in many cases for adults, I know I can't speak for Christine in Ireland or how it is in other parts of the world, but certainly in the United States, it's mainly in the community. People are not often going back to universities and the academic centers. Many people are staying within the rural or community area and getting care by the practitioners local to them. And I think really what's still the case, which is partly why we're doing this webinar, education and training. So we really do realize that there's a lack of formalized education and training, whether it's in epilepsy, whether it's in primary care, whether it's in nursing, whether or not it's in every aspect from early education and medical school residencies and training programs. Epilepsy, and again, our focus on epilepsy is because it's very, very, very prevalent. I mean, 3% of the world population does have intellectual and developmental disabilities, and those that do have developmental disabilities, it's thought that maybe a quarter of them actually have epilepsy as well. And why do some people have it and some people have it worse? Well, partly it's related to the degree of the brain dysfunction. Epilepsy is a condition of the cerebral or the brain dysfunction, and it seems to be more prevalent of epilepsy in those that have not just intellectual disabilities, but might have cerebral palsy, and also it might be tied into people that might have lesser IQ. Maybe more people with lesser IQ seem to have more prevalence of epilepsy more than they have more. And as Kristen, you had mentioned this too, is the increase of what's called drug resistance or medically refractory. It's not just having epilepsy, but challenging epilepsy, that medication called drug resistance may not be able to cure them or control them as well. And then Kristen, you also did mention SUDEP, and I'm going to talk about that in another slide. Seizures are bad. I mean, I'll talk about, this is not a great situation. People with seizures can have injuries and fall. They can bite their tongue, lose oxygen, swallowing problems. And then the treatment into itself is also can have toxicity from them as well. Quality of life is absolutely impaired tremendously. Their ability to go to work, live their lives, if they're having seizures or they're being treated with medication for seizures. And then, as mentioned, sudden unexplained death in epilepsy, which is a phenomenon, not totally rare phenomena in people that have uncontrolled epilepsy. So all of a sudden they're found dead. Is it from a heart issue? Do they have a seizure and their heart stops? There's some research on that, but it's definitely higher in the population that has uncontrolled seizures. Again, developmental disabilities have that in high. Status epilepticus is a situation where people have a seizure that goes on and on and on, minute after minute after minute after minute. And because of a longer seizure called status epilepticus that is causing lack of oxygen and metabolites building up in the body, leading to respiratory problems, metabolic derangements, and people can die from that. Also, what's called cluster of seizures is seizures that might happen, and then sometime later they regain their normal, and then shortly after that they have another seizure. So it's a grouping called clusters of seizures. So seizures are definitely an important thing as we're talking about as bad. So seizures in a lot of individuals that I'm referring to, it's not just seizures themselves, as a lot of the population, as we know in developmental disabilities, also have concurrent other medical issues. And it's very common in people with epilepsy with a developmental disability also have concurrent behavioral disturbances, probably more than 50%. And that's going to be very relevant in terms of the complications that people have. Behavioral problems, epilepsy, you put them together. I'll talk about that some more. Breathing problems, pulmonary dysfunction, risk aspiration is really risky. When people have a seizure, they're not swallowing well, they can choke. Swallowing dysfunction, neuromuscular problems, increased tone like in cerebral palsy, and definitely a plethora of gastrointestinal difficulties in this population, whether it's just swallowing difficulties or drooling or constipation. Very common. Bone loss is very common in this population due to perhaps immobility or due to medication usage. And if you have fragile bones, guess what can happen if you fall and injure yourself? Fractures. And if you have fractures, it creates pain and discomfort, or creates more immobility. So basically, a lot of these complications basically can swirl around and create more and more problems for the person as these accumulate through their lives. Nutritional difficulties, no doubt, this is a common problem that happens. And as certainly in the AADMD, the American Academy of Developmental Medicine and Dentistry, poor oral health, it would be amiss for me not to mention poor dentition, bone loss in their mouth, gum disease. It's very prevalent in this population with epilepsy. The psychological aspects of being epileptic and having epilepsy, there's a stigma approach to the E word, but somebody having epilepsy. Definitely, I mentioned quality of life as being impaired. People, if they have epilepsy that's maybe not be controlled, they might not think of themselves, I got epilepsy, and they're like embarrassed by it or having self-esteem problems. Parents themselves might say, my child's having epilepsy, I can't let them do anything. Oh my God, I got to protect them, put a bubble around them, the vulnerable child. So you can only imagine, take that forward, and what does that really mean for the parents and the children and people caring for them, because we're protecting them. But is the protection into itself a good thing, or can that lead to other problems? I'll leave it at that part, let you dwell on that. Depression, anxiety, attention deficit, learning disabilities, adverse effects of medication. And definitely, because of this talk and these presentations, we want to make sure that the parents and caregivers are very prevalent and a center to this discussion, because it's so much involved around families and caregivers. And what does that mean to them and the caregivers themselves about the stress and what they're going through themselves and helping support them? So these are not easy issues. The issues that we face in caring for the developmental population is very challenging and problematic. Refractory epileptic syndromes, and we're going to talk about some of them, multiple different seizure types. They might have what's called a drop attack, or they might have generalized tonic-clonic seizures or myoclonic seizure or different types. So some people in this population population might have different varieties of seizures. Frequent status epilepticus, as I mentioned, clusters too, is common. And then what does it mean for someone that has seizures and they're taking seizure medication for a long time? What does that mean for their body, their organs? And what about the fact that a lot of individuals who are having seizures also being treated with multiple seizure medication and multiple other medication, whether it's for behavior and other things? What does that mean for them? What does that mean for their body? What does that mean for their cognition? And what about if they're having side effects? How does one who's sometimes lesser verbal or nonverbal expressing themselves when they're feeling quote unquote dizzy or feeling tired or out of sorts from the medication? The side effect that they might be experiencing might be behavioral manifestation, and the overt behavioral manifestation might then be treated as behavioral abnormalities and giving more drugs. To do the math, it adds up to a big challenge. Diagnostic overshadowing is a term that we think a lot about when people with developmental disabilities are behaving in a certain way and acting a certain kind of way, and we're blaming that behavior. Oh, it's on their developmental disability. This is how everyone with autism acts. This is what someone with cerebral palsy acts. This is someone that Down syndrome acts. Rather than thinking that maybe there's something internally wrong. Maybe they got a condition. Maybe they got a disease. Maybe they got an ailment. Maybe they're in pain. Maybe they're having a side effect. So diagnostic overshadowing is really a bias. A side effect tolerance, the status quo. What are we dealing with? What do we say it's acceptable? So if you and I had a side effect and you're taking medication, how would you like it if you're feeling tired or out of sorts? I mean, I wouldn't say that happens all the time, but do we accept that? Well, the good news, the seizure are better. The bad news, you're kind of semi-unconscious. I mean, that's a dramatic comment, but I would say that's how I mean. Do we have enough data? Do we have the communication of all this information to be able to make sense of what's going on? And then also the transitioning of care. And it's really not only transitioning from the pediatrician or the pediatric neurologist to the adult neurologist, but transitioning happens throughout our lives, even in the geriatric population as well. And I just have that one picture there by a philosopher Paracelsus back in 1493, he lived till 1541. And I always put this comment up there because I really think it's very relevant to treatments and medication we provide. And his comment, which I always like to mention, all substances are poisons. There's none which is not a poison. It's the right dose differentiate poison for a remedy. So anything we take, whether it's over-the-counter prescription medication, does have a chance of being too much for people. So we have to be very careful on what we're providing. What we're going to be doing in our web series, we're definitely going to be speaking a fair amount about genetics. And this slide, I really wanted to, it's a busy slide, but I really wanted to talk about over the time period from the early 1990s and even beyond up until our recent time period. This is just a small nugget of showing how genetics have been showing more and more about the uncovering about how the genetic anomalies and changes are being found in the developmental population. Dravet syndrome, tuberous sclerosis complex, Rett syndrome, and others. Definitely, we're finding more rather than saying, oh, this is a non-specific developmental disability. We don't know why they are. Maybe they had some birth issue. I see that because I'm an adult neurologist. We don't know in many people about why they developed a developmental disability from birth, but genetics in many cases seem to be the case as driving it. Now, why is that relevant? Well, it's very relevant for a lot of reasons. And I'm going to talk about that as we talk about treatments. So this slide and the next few slides is really going to give you some basic overview that we're going to, in our next series of webinars, we're going to just go into a lot more detail. So again, this presentation is really more of a general overview. For those that treat epilepsy, and this is kind of what I do on a regular basis, we use various treatments. It could be a seizure medication, it might be dietary, it might be brain stimulation, cannabinoids, surgical. So how do we, what do we do? So most cases, what we physicians do is we do pills, as one would suspect. So the pills themselves, and this is another busy slide, there's pills and then there's pills. So basically, I've been practicing neurology. Oh my God, I don't want to show my age here. I've been practicing from the early 1990s. So from the 1990s, I've actually been introduced, and this is a slide that shows a lot of these different seizure medications, generic names as they are, is they're showing how the seizure medication had developed from the 1930s in the later time period. And there really was a big boom of new seizure medications probably around 1980, 1990s and now. And so I wouldn't say every day we're hearing about new different seizure medication coming out in the market, and they would use the term like the first generation anti-seizure drug. That's what the ASD stands for. So there's been really a great number of seizure medications that are coming out. And the reason why is because they're hard to treat. Epilepsy is a very difficult condition to treat. So there's a lot of room for improvement. So the pharmaceutical world, the world of biochemistry and all world of research is showing that there's a lot that we're really learning from really trying to find a lot of these different seizure medications more and more to help. So we're definitely at somewhat of a better place now of having various options, even including recently in the last few years, that is targeted towards genetic syndromes. That's going to be my next slide. The usage of cannabidiols and fenfluramine as other medications that have actually been showing benefit for what we would call almost like a targeted or precision approach. And really what this slide is really showing is that in the last number of years that we're finding the genetics that do cause some of these syndromes, like I mentioned, Dravet or tuberous sclerosis or others. And because of those anomalies and genetic changes, the scientists, the researchers, the industry who's finding help for these individuals can see that there's certain pharmacologic measures that might be able to affect people or improve their situation based on some of the anomalous gene changes. So we would really call it more precision therapy. And I'll give you the opposite of precision therapy is what I would do for most of my life. I would say throwing a dart at the wall is basically, well, let me try this drug. Let me try this drug. It's almost like, I would say it's arbitrary. You might want to see me as a neurologist, like Dr. Keller, arbitrarily giving drug to people. But it really is somewhat like that. I mean, I tried this. It's like a shell game with different medications, but it certainly wasn't ever proven, I don't think, in my world, that the accuracy, the ability to be precisionally affecting people. So this particular study came out just recently, and it was really related to the genetics of Dravet syndrome. And this is just showing the last several years about how Dravet syndrome in particular as a neurodevelopmental condition is having more and more found out about its underlying genetics and how the precision nature of pharmacologic care might be more effective based on the anomalous changes that they have internally within their chromosomes and body. Cannabidiol, as also as mentioned, has been also shown in great research over the last decades. And this is just showing just a plethora of some journal articles that had come out in the covers, a wow factor, I guess, about it, about how the cannabidiols, the CBD component, has been very instrumental to reduce seizures in certain populations. So and we're going to have a presentation that's going to be really focusing more and more about this. Again, this is kind of wet your whistle on some of my discussion about this particular product and this type of avenue of treatment for this population. And this is just a slide that's really showing some of the active ingredients in marijuana, which is basically the THC versus CBD, and why one might be more of a psychoactive high kind of component as compared to the CBD, which might be more protective against the brain. That's just a slide for that. These medications don't always work, so we have options, surgical treatments, whether you can actually take out a region or focus of the brain. That would be, a wonderful avenue to do in people that are not getting great control of their seizures. Palliative treatments, palliative means you're controlling the seizure. Instead of like curing them in a way, you're basically reducing the number or severity of the seizures, and there's different brain procedures that are done for that. And we are going to have more of a presentation on that. Dietary measures, the ketogenic diet, there's several varieties, and we're going to have a great presentation next time by our great colleague, Kenzie Cervenka, who's really going to be talking about GLUT1 deficiency as a particular dietary measure in her presentation with the GLUT1 deficiency organization, which is going to be talking about that in the case report and show how dietary measures. But definitely various dietary measures have been trying to show low carbohydrate, low protein, high fat, and the ability to kind of find different ways and certain populations of individuals with developmental disabilities to show how those dietary measures are effective. Is this something that's more beneficial for a child? Is this something that could be done for adults? So I'm going to leave it at that because I don't want to steal Kenzie's discussion because she has a great presentation on this topical area. As a neurologist that also does neuromodulation, I've been very frequent to use the vagus nerve stimulator. Other avenues of usage of what's called neuromodulation is electrical stimulation to the brain and the neural pathways to have a different way of trying to reduce seizures. Deep brain stimulator, responsive neurostimulation, transcranial magnetic stimulation. And so there's different ways. And this slide just goes into some of the nuances between the vagus nerve stimulator. And for those that, it's been around since, I believe, 1997, when I believe it got its first approval for the treatment of partial onset seizures and trying to reduce the nerve seizures. And then more recently, in the last number of years, the responsive neurostimulation and implantation of device that actually, in one way, can actually sense a seizure happening and basically almost like do an auto stimulation and almost stop a seizure or reduce a seizure from becoming out and actually having it. And there's data that definitely shows the reduction in seizures in using these different techniques. So it really comes down to, I'm giving you this discussion here about who's appropriate for this and what individual gets that and what have you. And I just wanted to also just add seizures that still occur. It's always the important thing, of course, about the action plan, the ability to treat an active seizure from happening, the first aid in some respect. And this is from the Epilepsy Foundation, put this nice picture graph out that really shows the first aid of the caregiver, the family member who is looking at the person and what they do to ensure the person not having harm by the seizure themselves. And then the usage of what's called rescue medication. Rescue medication traditionally would be a medication like a benzodiazepine, typically Valium or diazepam or midazolam. And the picture on the side is the rectal suppository. It's been out for a long time, and then more recently some of the nasal spray preparations that are used to help get the medication into an individual that's having an active seizure that might be either a cluster or prolonged seizure, to reduce it so they don't get hurt and they don't have to even go to the hospital emergency room. And then what do you do after that? The follow-up plan is always important to do. Nursing supports, I mean, we're going to have a great presentation on nursing supports. I'd be amiss if I didn't talk about the great importance of of other individuals, the direct support professionals, the family members, caregivers, family, and nursing in terms of spec. And I would say I wouldn't die without a nurse, but it's an amazing important thing. And people that are in group homes and other organizations that have another health person like a nurse that can add as a liaison between myself and the group home and other caregivers and the family members. So definitely we're going to hear a lot more in our presentation about the importance of nursing care and supports. And for me, it's the feedback, the monitoring the epilepsy, the ability to monitor and know about adverse effects. And then the other thing is that even though I'm a neurologist and I treat epilepsy, I also about the other comorbidities, behavior. What about other complications and the information that I need to hear about that? And so I'm not living in a vacuum. I'm living in a world with other care providers who are also going to be very important for me to hear about that. So we definitely are in a team effect to kind of do this. So we have to have the healthcare provider. You have the other profession. You might have a psychiatrist. You might have other gastroenterologists, pulmonologists. You're going to have another provider. So really the coordination of care is extremely important. And then again, the first aid of seizures in terms of how that's carried out and who does it. Education and training, hugely important. So being able to have the family members, the carers and the caregivers to be able to really know how to treat and care for individuals is really it's so vitally important. This slide really just is really more of a philosophical slide that I really, because this is a global discussion, is care, how is care really be provided? Is there really equitable care? So here in the United States, is the care in the United States equal to what it is, say, in Ireland, or is it in Ukraine? And just as an aside, and I could talk all day about Ukraine. I had just visited in Ukraine in June of this year as part of a disability rights organization called Disability Rights International, to really go into the country and see institutionalized care and how care is being provided. So I got a firsthand look about not only just Ukrainian care within the institutions for people with developmental disabilities, but the geopolitical challenges that a country like Ukraine is facing. So the issue about all these factors, about the geopolitical nature of your country and the places where people live and how that may impact upon the care delivery for this population. The advocacy, I mean, here we are, many of us probably on the call, or all of us are advocates. So that advocacy, just in the historical nature of how did care improve and lifespan improve in the United States, around the world, is advocacy really was driving it. Regional differences matter. I know that certainly in the United States, it might matter if people live in a city versus rural. Are you in the north, the south, the east, the west? I imagine for those that are on the call, for you in whatever countries you're calling from, you might see the same differences between where people live. Is it really fair? Is it right? But regional differences matter. Cultural changes, certainly. I think there's also an issue also about the cultural mores, about what people feel about developmental disabilities in terms of their own feeling about whether that's from the eastern part of the world or the western part of the world, the north, the south, wherever people live. Where's the history? Where's the culture, and how aspects of even how people even think about developmental disability individuals, about epilepsy and such like that. So really culture matters. Race matters, unfortunately. It really does seem to matter. There's stereotypes, there's stigmas, legal issues. Certainly in the United States, we're a very litigious society in the United States. So sometimes lawsuits have been pushing the envelope to get things done. The American Disability Act and other avenues of the Olmstead Act in the United States to get people out of institutions. So we use lawsuits, and unfortunately, sometimes when lawsuits occur, it's usually on the back of an individual that was damaged, hurt, or had some bad outcome. And so someone sued and we got to change the factors. What is the environment going to do now with global warming and other aspects of the world, the cold, the heat, the changes? What is that really going to do for access to care? And social justice. I mean, really just social justice is huge. This is a civil rights issue. This is a social issue. This is a personal issue, even though we're going to be talking a lot, of course, in our next, all of our webinars about the academics and the research and the medications. But really, folks, think about this along the way as we talk about individuals and how much important to care about them as people and the rights that they have of getting equitable care and the fairness to them and how unfair it is in the other way of looking at it. Without appreciating all the advocacy groups, this is just a nutshell of the global effort for just some of the advocacy organizations that we have to listen to them and care for them and really communicate and collecting information from sources that they have and partnership with them and taking a team. And I just put in some of the organization from the advocacy side, and this is several of many, some mostly in the United States, but around the world. People that have family members and run organizations around the world, they go to sleep every night. They wake up every day loving, caring, supporting that person. We owe it to them in the community of healthcare providers to owe it to them to care and support this population. This is just a listing of the presentations that are going to be coming along the way. And we're actually blessed by having a number of amazing speakers from both the United States and all around the world who are top-notch experts in their field, covering a good number of these various issues that I kind of went through quickly here. And we in the AADMD are going to be giving out information. This particular presentation is going to be archived for those who weren't able to be on. But each of these presentations, just like with Christine being on today, we're going to have each of these presentations be very centric to families, very centric to individuals, organizations that are supporting people in the community and in their countries, and advocates. We want them to be very centric to it and not make this a purely academic discussion. Wow, I don't think I can say anything else, but I imagine there might be some questions. Oh my God. So that's kind of, I'm out of gas. I mean, I probably I know Christine, thank you for listening in, and Grant. So friends, I'm done. I'm actually, what I can do is I can stop sharing right now. Grant is the moderator. I can maybe throw it back to you. Let's go. We have about 15 minutes or so. Maybe I didn't take one breath. So basically, I'm going to run for oxygen right now.
Pause and take a breath, and I'd invite the audience members, if any of you do have any questions, the Q&A section, or even just in the chat, to go ahead and drop them. I haven't seen any yet, so we'll continue to wait for that for a little bit. But I did have a few ideas that kind of came up while you were talking, and since we have Christine here, maybe we can kind of pass the questions back and forth. You mentioned equity in healthcare for this patient population, for the IDD and epilepsy population, and you talk about the international efforts that you've seen. So who do you feel is really leading the way in this care? Like, we have the ILAE and their IDD task force. There's the AADMD and their work today with what we're trying to push forward, as well as various other efforts. Do you guys have in your minds either a institution or a group of physicians that is really pushing the way for this type of care and academic research to be done?
Christine, you want to tackle that? If I'm saying you got the whole world at your hands, right, Christine? International. So what do you have to say, Christine?
Yeah, I guess I am fortunate. I mean, look, it's a small enough field, to be honest. I would have to say that to start with. But the organizations that you've mentioned there, Grant, I think are really pushing this agenda. So certainly the ILAE, the International League Against Epilepsy, the very fact that there is a task force on intellectual disability, all of their conferences would always have a session on this area. So I think they are leading the way, and I'm very lucky that, if I recall, I have 10 colleagues from all over the world on our committee. So where one region they're excelling, in another region they're not, and vice versa. So we learn a lot from each other. I don't think there's a magic wand out there, truthfully. And I think that probably goes back to the equity issue. So the non-medical issue, if I can say. I think that there are serious questions to be asked about stigma, discrimination, and the lower expectations that some healthcare professionals will have of this population. So I've had it said to me that folks who have an intellectual disability are not good candidates for X, Y, and Z treatment, because of the fact that the likelihood of them becoming seizure-free might not be as high as some other people. And I just think that's kind of really quite unacceptable. If you look at the UN Convention on the Rights of People with Disabilities, I think everybody should have the same access, that is a protected human right. So I think if we push that, then more and more of the learned international organizations, they'll be out of step if they're not addressing this issue. But I think you captured most of them there, truthfully. I mean, one of the things, and Seth, just to say, that was a wonderful presentation. It made me think of so many things and how you got so much in such a small time period.
I talked a lot, yeah.
Yeah, well, it worked for me. But I guess just to say that one of the things that we're kicking off with in our group in ILAE is to get the voice of people with intellectual disabilities themselves. And one of the things that we were looking at was easy to read materials that are available for people with an intellectual disability to understand epilepsy, understand the condition, understand possible treatments, monitoring their condition, etc. And it's not good. There's some excellent resources out there, but they're predominantly in the English language. They're predominantly from 1 or 2 countries. And there's a real gap out there. So I think not only do we need to be communicating to the medical profession and to the caregivers, the families, etc., but we really are only having a one-way conversation if we're not including people with intellectual disabilities. What do they know about epilepsy? What do they need to know? What are their fears? So we do want to do that kind of consultation and really bring those folks on board in a conversation.
Yeah, Christine, well, actually, one thing, I was going to make one comment, but actually, as I see some comment, thank you very much for the comments that you were making. In the last, we were going to be off in about 10 minutes. So for those who are on this call, it would be exciting if you could actually tell us who you are and where you're from. So you can flood our chat box. Please tell us where you're from. It'd be great. Well, anyway, I'm going to add into the comment. This is a personal issue. So what you're saying, Christine, about having the face of someone with developmental disabilities, absolutely, this is personal. This is an issue with the face of the people, what it's for them, their message that they're having. This is not yes, it's academic because we're prescribing medication to research, blah, blah, blah. But this is about people and their lives. And you got to really make it so personal and fill it up with a heart. You got to make it very personal. And I wouldn't say I'm trying to guilt anyone, honestly. Well, maybe I am. Yeah. How can you not care for people? And if you're not caring for the people, what's wrong with you? I mean, what's going on with you? Why are you not caring for them? And think about, look yourself in the mirror about, why are you discriminating? To me, it is a form of discrimination. And again, I hate to be throwing anyone under the bus, but people who are brought up in certain societies and certain cultures from day one of their life and all around them, if all you hear about people with developmental disabilities don't have work, don't have value, don't have that. And I learned that in Ukraine. I mean, again, I'll bring Ukraine up a little bit. I was really, I hate to say shocked, but I did a history lesson before I even went to Ukraine, and I really got to see what their culture was. And I wouldn't say everyone's blameless in some regard, but if all you know is what you know is nothing, then what are you going to do? You have to learn. So what I was thinking about in terms of this whole global reach is listening. and helping out and holding hands and learning together, improving things. And whatever I may do in the United States may be different, and I can learn from each other. But definitely there's a lot we can really learn. And one thing that's also going to be making a difference is mandatory training and education. So right now, there's nothing mandatory in training physicians, neurologists, that they have to learn any of this, what you guys just heard on this call about adult care for epilepsy. They don't get it. They're not getting education around how to treat an adult with developmental disabilities. I didn't get it. The only thing I got as a neurologist is 3 months in my neurology rotation and pediatric neurology. So I got to see little babies, little children, many of them without a developmental disabilities. And I didn't learn it. I didn't learn a lot, but that was really my only probably notice or information that I could learn about developmental disabilities. I started learning it when I saw people in my own practice, and I tried to figure it out. So it's really where I think physicians themselves are somewhat of a disadvantage of adults with developmental disabilities. They don't have that exposure, they don't have that experience, they don't have that knowledge. And then what about the challenging visits with them? And they don't have the information, and they have a genetic syndrome. And so to me, it's mind-boggling sometimes for some of the practitioners to say, oh yeah, no big deal.
So Seth, I hate to interrupt here. I want to make sure that we field all of these questions that are coming in.
Okay.
Do you want me to just kind of read them off to you guys?
Go. You want to go ahead?
Great.
Courtney?
Okay, so this first one comes from our friend Michael Sewell. Can Dr. Linehan please provide the name of the 2 IDD groups mentioned?
I can indeed, yeah, sorry, it's my Irish accent, I think, is coming against me. So the letters for the first one is ILEA, and it's the International League Against Epilepsy. They have an excellent website that is predominantly for physicians and healthcare providers who work in the epilepsy field. The second one I mentioned is a little bit longer, so I hope you have your pens to hand. I say IASID, I don't even know if I pronounce it right. IASSIDD, otherwise known as, brace yourself, the International Association for the Scientific Study of Intellectual and Developmental Disabilities. And somebody's just typed in IASID. That's very helpful. Thank you to the person. Oh, thank you. IASID is it's an organization for people with an interest in intellectual disability, and there's a health special interest group there. The group that I chair is Comparative Policy and Practice, which speaks to Seth's point earlier about learning from each other. But those are the 2 anyway. I'm mindful that Courtney has to go through the questions, so thanks for the question.
All right, so our next question came in through the chat box. She said, I have a query as a caregiver of someone just diagnosed with epilepsy. While wishing to respect our son's privacy, who should be made aware that he has epilepsy? And is it best to be wearing a medical bracelet?
Grant, I mean, you have any? Grant, you're a great guy. You might have some good thoughts on that.
So what I would do in this instance with your son's diagnosis is it really depends on how old he is. If he's 18 or of the age of an adult where you're living, it would have to be deferred to him who he would inform and who not. But if he is younger than 18, I would really encourage him to think about who it would be safe to know that he has epilepsy, such as his teachers, his coaches, other family members that might be taking care of him or watching him. And even his work, it would be particularly important. If there's ever an instance where he would be, under somebody else's supervision and he were to have a seizure and they wouldn't know what to do, that could lead to some significant harm for your son. And that's what we all want to avoid. In that same vein, I would recommend that he would wear a medical bracelet, because if something were to happen and he was in a situation where there wasn't somebody supervising him or that individual didn't know what to do, when EMS arrives, they're able to see that bracelet, have information about his diagnosis and what's going on and how to best next proceed. There are a variety of ways you can get medical identification bracelets that actually look kind of stylish, rather than the old where it's just like a metal bar. You can get ones that are colorful and draw the eyes of the EMS that are worn in certain areas so they know to look for them. So that's what I would recommend, and that's what I've recommended to my patients as a child neurologist.
All right, and our last question has come in through the Q&A box. It says, Seth, given the number of patients we have shared over the years, it was good to see the link between epilepsy and psychiatric and behavioral comorbidity. I might add, especially in the history and socio-political issues, and with the possible exception of specifically AEDs, and even here, there are dual use drugs and neuromodulation. So
Modulation, neuromodulation.
I butchered that one. Treatments. One could replace epilepsy with psychiatric disorder in the slides with little modification. So I guess that was more of a comment.
So yeah, it seemed like more of a comment, but it is very true. A lot of the things that Seth talked about, and sorry to steal your thunder here, Seth.
No, go ahead.
A lot of the things that you talked about, whether it's the AEDs, neuromodulation, the comorbidities of chronic use and polypharmacy, a lot of these medications can have behavioral side effects for either improvement or worsening of behavior, depending on the patient themselves. Yeah. So knowing your patient, knowing their diagnoses, knowing what's worked for them in the past and where you'd like to take them in the future is going to be really key in terms of taking care of that individual.
Yeah, and one part of that, Courtney, is that is very true. One of the challenges, again, there's good news, bad news. The challenge is that if you have different providers that are prescribing one medication for, say, behavior, like say I'll use carbamazepine, Tegretol as an example, which is it's a mood stabilizer, but it's also used for partial seizures. So now I have a patient that's on it also for partial seizures. So how does that mix between what I'm trying to do or what they're trying to do? So it does create interesting communication issues about medications and sharing of information between one provider and the other provider. When one provider says, I'm going to go up on this, so I'm going to stop this, and the other provider. So it has to really go back to communication is key about what each is doing. And the team approach is always the best case scenario if that can be provided, which is not always that simple to do.
And we have one last question in the Q&A box. It comes from Michael, I'm just going to butcher everybody's names today. Mark M. With improvements in maternal fetal health and preemies living longer, is the incidence of epilepsy increasing?
So may I take this one?
Yo, Grant, please go ahead.
So again, as the child neurologist here, I kind of feel like this might need to be taken apart a little bit to answer. I think in the initial time period, we are going to see an increase in the incidence of epilepsy because the younger a premature infant is, the more likelihood there is for intraventricular hemorrhage, other neuro lesions to accrue due to the significant health complications that they'll have in those premature time periods. Their brain not being fully developed, not having the type of nutrition that they're supposed to be having is going to lead to things downstream. However, as we improve our prenatal care, it's my optimistic hope that even though we'll see an increase in epilepsy kind of long term, that we'd see a decrease in that as that root cause is better taken care of over time as our science continues to advance, as our medications and interventions continue to advance. So not a specific answer, but kind of what trend I'm seeing as a child neurologist.
Good deal. So those were all of our questions that we had from the audience. Do we have any kind of final thoughts from our panelists?
Well, I'll just start. I'm thrilled that this is our first talk out of the way. This has been in the planning. I mean, just for us on the team and Grant in particular. Mike Sewell, you're out there, and I know you're part of this discussion. Hey, Mike, is that we as a group, an organization, have been really working hard for years and years and years to really want to get education and training out. And really, we're just thrilled because, with all the support of my colleagues and friends and the pharmaceutical industries that are supporting us in what we're going to do, and other organizations like ILAE, and having Christine here, I think this is great. I really look forward to moving forward and having our other talks. And I want to deeply thank you for all the support and being able to have this talk today. And I look forward for others in the future. Christine, comments?
I just want to say this was excellent, Seth. So many thanks for the invitation. The fact that you have a series of these and the lovely comments that are coming in about your presentation. The more people we can get involved, the better. People with ID, they really deserve the very excellent healthcare that you guys provide. So I think this is wonderful, and it was a real privilege to call in from Ireland. So thanks for the invitation. It's an open door you're pushing for me, so you know that.
Absolutely.
Thank you, Christine. Grant?
Well, I just saw one final question come in from Mr. Gibson, Brandon Gibson. He is asking, when is the next part of the series? So again, that is January 18th at noon Eastern Standard Time. We're having Dr. Mackenzie Cervenka talk about diet therapies in epilepsy treatments. And we'll look forward to that.
Wonderful. Courtney, I think it's a wrap. I think it's a wrap.
Yep, we just want to say a thank you to Jazz Pharmaceuticals for making today possible. And I wanted to remind everybody that you can watch today's webinar and the rest of the series on our Mighty Network. So you just go to network.aadmd.org, and this is how we continue the conversation and stay connected. So we're not going to be a one and done webinar. We're not going to be a one and done webinar series. We're here to stay. We want to see these connections happen and see education really get out there. And then you can also apply for CME for today's webinar series. We put it in the chat box there, and the link in the chat box, and we'll also include it when you log on to Mighty Networks to watch this. You can also click on there to get your CME. Should be pretty easy.